Thank you for joining us today. So I'm Chris Witowski of Psilera, again, a next-generation psychedelics company. I quickly want to start with a broad overview of Psilera. We started the company in 2019, before really the psychedelic hype, if you will. Since then, Jackie and I, my co-founder, have really assembled a great team, over 100 years of biopharma experience. Our prior startup also went public for over $1 billion, so in an adjacent space. And really what we're focused on is two main pillars, one of which is drug delivery technologies of existing psychedelics. We have partnered these programs, but also in these neuroplastogens or next generation psychedelics, which really have the potential to be best-in-class drugs across neuropsychiatric and neurodegenerative diseases. So early last year, we did a partnership with Atai-Beckley on two of their late-stage assets in depression. So the headline deal is $83 million in milestones. We've already generated a significant upfront payment there. And the royalties on these products, both late-stage clinical assets, we think could be substantial as they're going to compete with Spravato in a short-acting psychedelic format. We also received a $2 million grant from the NIH to study alcohol use disorder with our lead drug, SIL006. And we also had a term sheet from a major strategic biopharma company. We are now discussing an equity-based transaction with this company. So I want to talk a little bit about our neuroplastogen workflow. It all starts with our Psilera Third Eye screening platform. So this is a computer-based drug design, so we're able to look at targets of interest, such as serotonin 2A, which I'll talk about a lot today, which is one of the most well-known drug targets within the CNS. This allows us to iterate drugs very quickly, see off-target effects, on-target effects, and predict potential hallucinations from these drugs very rapidly. From there, we have generated our first clinical candidate, SIL006. It is the first selective 5-HT2A, 5-HT6 partial agonist, and will be in clinical development in about 12 months' time. This candidate has really broad activity that you see with this class, anything from psychiatry, mood disorders, learning and memory and cognition, addiction, as well as neuroinflammatory markers and sleep that will help translate into a clinical patient population. So our first indication with this drug is in frontotemporal dementia, which we think we can generate rapid data with high degree of confidence. FTD is a rare disease. There are no approved treatments. Even the off-label treatments are not effective in this disease. We've generated a very targeted neurotherapeutic that targets the underlying pathology. So these are diseased neurons that are atrophying and dying, a hallmark of neurodegeneration. Also targeted neurocircuitry with deficits in serotonin. And the symptomatic benefits that we see in sleep, in mood, and other areas in cognition that really are detrimental to the patients and their caregivers. From there, areas such as dementias, dementia-related apathy are huge indications with unmet need, 3 million patients in the US alone, that we can help translate our FTD data into a larger population. As I mentioned with AUD, this is a significant unmet need. Roughly only 10% of patients seek treatment because currently the standards of care are terrible. And we have already generated strong pilot data to almost completely abolish alcohol consumption in these animals. It's something that's known with these 5-HT targeting agents through clinical development, and there are significant non-dilutive pathways to advance this in the clinic. Quickly, I wanted to kind of highlight a high-level target product profile of 006 in FTD. So the first of which is a hallmark of the neuroplastogens is a non-hallucinogenic drug. And what this enables is take-home dosing, which will increase patient access, not only to FTD, but a lot of other indications. But also within this patient population, hallucinogenic effects will exacerbate psychosis risks, agitation risks that are hallmarks of neurodegenerative disorders. So we think this actually makes a safer, more tolerated drug. 006 is orally bioavailable, has strong drug-like properties, gets into the brain and CNS at high concentrations, and reduces some of the liabilities and off-target effects such as 5-HT2B, hERG, and other enzymatic targets that we don't want to hit with the first-gen psychedelics. We have done early safety and toxicology, demonstrating a strong therapeutic index with our drug, and we've already completed pilot manufacturing in cGMP formats. So as I mentioned, 5-HT2A is quite frankly one of the best known drug targets in all of CNS. Most of these drugs start off as antagonists, known antipsychotics, and the way we tend to visualize the sweet spot in this receptor is a gauge. So at this end, on the left end, too low neuroplasticity, these are antagonists. It reduces receptor function. You don't get neuroplasticity. Well-known drugs in the antipsychotics. On the other end of the scale, too high hallucinations. These are your traditional first-generation psychedelics, things like psilocybin, LSD, that have rapid mood benefits, but also have the off-target or side effects of hallucinations. So what we have shown, and others, is by creating the sweet spot of this partial agonism at 5-HT2A, we can afford the neuroplasticity benefits, rapid behavioral, symptomatic benefits without hallucinations. We've demonstrated this with the head twitch model. It's a very well-validated rodent model based on head twitches. Higher head twitch means a more hallucinogenic molecule. Our drug, typically therapeutic benefits between 8 and 20 mg per kg. We don't see any head twitch. We've also demonstrated in vivo target engagement. So by dosing our drug at 8 mg per kg before, this would be psilocybin analog, producing a known hallucinogenic drug, we actually reduce the hallucinations. So the drug gets into the brain, has a targeted effect that we think is beneficial to patients. And this is some recent data that we've generated in human-derived iPSCs in patients with a C9orf72 mutation. So this is a genetic mutation that occurs in about 50% of FTD patients and also the majority of ALS patients. So these neurons were cultured in the presence of activated microglia. So microglia basically create a cytokine environment that deteriorates neuronal function, reduces LTP, neural firing, that we rescue with our drug at low physiologic concentrations. And it does this both rapidly at 1 hour and with also durable effects through 12 hours. So this also lines up with what we see in our animal models across therapeutic benefits and the durable activity of this drug class. Apathy is a significant risk to patients in dementias. It's actually the main cause of reduced quality of life and life expectancy in patients with dementia. In FTD, apathy affects over 80% of patients and about half of general dementia patients. There are clinically validated rating scales such as DARE and NPI-Q to target these neuropsychiatric apathy symptoms. And there's also a regulatory precedent with fast track designation for dementia-related apathy. We've actually generated this tetrabenazine-induced apathy at the request of a potential strategic biopharma partner. And this is a well-validated model. Tetrabenazine is a known dopamine-inducing molecule that reduces motivation in animals and in humans. So what we see with tetrabenazine alone is reduced motivation to work for a nice sugary reward. However, with our drug, we reduce and rescue the apathy benefit in these animals and restore normal function. I want to summarize with our current pipeline. So I mentioned the two partnered late-stage assets in clinical development with Atai-Beckley, a really strong team, and we think there's a strong potential to get these drugs commercial in the next few years. And 006, we also have a pro-drug approach for other related indications, dementia-related apathy, AUD, as well as FTD, and a strong pipeline behind it. We are here raising Series A capital to generate clinical proof of concept in 006, and we are fully funded today to get to IND by end of year. Last but not least, I want to mention we've recently announced Magali Haas as our Chief Medical Officer and included Scott in our corporate development team. I think I'm a little bit over. Thank you for your time. I'll be outside if you have any questions.